Next is my thinking and strategies to avoid facet joint arthritis. From Dr. Berg.
Thank you, and this works probably. Thank you very much for inviting me. It's a pleasure to present to colleagues that are so interested in the piece of work that I'm so interested in too. I've been quoted on some studies earlier on discography and also on randomized control on disc prosthesis cases, and we'll get back to that a little later. I have nothing to disclose. I have a personal experience since 96 with total disc replacements. By now I've implanted about somewhere between 3,000 and 4,000 cases with different brands, of course, since time has changed and our knowledge has increased. The randomized control study from Sweden that I did was quoted, and that was the 5-year results. Both the 2 and 5-year results were published in European Spine Journal, and the 10-year results are under writing. And as time goes on, the advantages of the mobility preservation obviously increases. Not that they get even healthier, but they avoid future problems as adjacent segment disease and so on. I have no personal experience with the viscoelastic implants. It's interesting what I'm telling you as my, not presenting a new study, but my experience from all these cases is from mechanical disc prosthesis, but I think a lot of it goes for the viscoelastic too, because it's a form of thinking. We have factors that affect the long-term results when we treat DDD. Infusions, if they heal, we are to start worrying about adjacent segment disease. Depending on the longevity of the follow-up, the figures that has been published reach between 35 and up almost 40% that develop it. Adjacent segment degeneration, on the other hand, is even more common, of course, but if it's quiet and non-symptomatic, it's not a problem. But for our beloved motion preservation, we also have things to consider that would affect our results negatively in the long run, and we wouldn't like that to happen, would we? We don't know how common it is, depending on different techniques, prostheses, patients, but it's a problem. So what can we do to avoid facet joint arthritis? The facet joint arthritis is mainly caused, if it's not through translation, as we discussed earlier this morning, it's because we shift loads from being through the vertebrae and discs to be shifted over to the facet joints. They are actually created to direct mobility, but not to unload the weight bearing. So in my practice, I do a lot of things to try to avoid the creation of segmental hyperlordosis. It's on the patient side, it's on my side as a surgeon, and it's also on demands on the implant producers. They have to listen to us and fully understand the challenge. On the patient side, we must realize that the first day that our patients discovers that they have low back pain, they start to contract their back muscles. And this will probably go on for 1 or up to 5 years or whatever until they reach us for surgery. So by then they are extremely strong and short in their lower muscles. At the same time, they are probably low in 1 or more discs, making the relatively shortness of the muscles even more pronounced. So my patients had to change this. They have to stretch their back muscles a lot prior to surgery. Supported stretching, not free bending, and we do this under the surveillance of a specially trained physiotherapist. They also have to strengthen the counterforce, the straight abdominal muscles that are the only muscles with a good level arm to protect against segmental hyperlordosis. This is in the meaning to balance the lordotic and kyphotic forces when they have a restored teenager mobility. And as I said, they do it under surveillance of a physiotherapist that is especially interested in this field. So it's a demanding thing for when patients reach me. I demand from them if they're going to have the mobile solution. Overweight is another thing, because especially if it's abdominal overweight, it always creates an increased lordosis in a pregnant woman, and that has to be coped with. Also because it's almost impossible to reach down in the very fat belly to do anterior surgery. If you look at these pictures, this patient, you have the flexion extension prior to surgery. She had an A-lift, 20 degrees A-lift at the lower segment, but as you can see, postoperatively she developed a quite increased lordosis at 4-5. That was not because the disc prosthesis that I put there had any angulation at all. It's a free angulating thing. It's because I restored height, and the ligaments and muscles were so short, so they forced her into lordosis in a non-physiological way postoperatively. This can be changed. This is pictures taken day after surgery, and if we can make her enthusiastic to a lot of stretching, it will probably change when she gets back at 3 months. But it has to be noted and clarified for the patient. As a surgeon, I know that a too high implant, the only thing that can do when I've cut the anterior ligament is to shift the segment into lordosis. And the early implants were too high. When I did my study in 03 or 04, it was the Charity, the Maverick, and the ProDisc that was in it. Most of them were too high. So I overstuffed most segments, and that is another way to get facet joint arthritis. If we don't put the implant all the way to the PLL, but in the frontal part of the disc space, it will immediately go into a locked extension where they're hanging on their facets. They won't have any good extension movement in that, but they are blocked in a way where they're hanging on the facets. So the prosthesis has to go all the way to the PLL to get the height increase of the posterior part of the disc. We also, as has been told earlier today, we have to mobilize the posterior structures because they are shortened and wrinkled and scarry, and we have to mobilize them to give the possibility for them to balance their sagittal balance later. If we have a multi-segment case, one segment is too hyperlordotic for me, as we've been discussing just recently, to use a total disc replacement or have already facet joint arthritis, then I advocate to consider an A-lift with a sufficient angled implant. It has to be at least 15 and hopefully sometimes even 20 degrees to cope with the angulation at that level. because if they have a strong angulation in L5-S1 and I put a 10-degree ALIF, I will force the patient to go into hyperlordosis in the next level where I put the prosthesis. So when we choose to make a hybrid, we have to see to that we have angled implants enough. This is an example of how I do hybrids. Doesn't differ from what we've seen before. In this case, it was already some facet joint arthritis, probably because that patient had been stretching, walking around with a lot of angulation in L5-S1, and that tears the facets down. So, but in this way, with this angulation, you can see there is no shift into lordosis in the 4-5 where I put the disc. Another reason is the combination that is not rare but very common, that patients have spondylolisthesis in one segment and DDD in a neighboring segment. Then earlier on I would have fused the patients from posterior 2 segments, but the last 10-15 years I've shifted, and I would do a hybrid on a case like this to maintain mobility at least at one segment, and that is probably sufficient in most cases. If you can see this patient with a very, very low disc L5-S1, it's being a low disc is not something that hinders me from using artificial disc replacement, as long as the facets are healthy still. And that patient would have been much more lordotic in that level if they wouldn't have stretched. Now it's too little lordosis, but that is easily coped with when he starts walking around. This is also just taking the day after surgery. I never, with mobility, have a problem of too little lordosis. They all find it. Nobody wants to just look at another people's feet. They want to see the horizon, so we always get the lordosis we need. And this could be a typical case for a 2-segment artificial disc replacement. As to this discussion on discography, my article was quoted here. I use it, in the 80s, I didn't fuse any patients without discography, but we didn't have MRI available in the way we have now. So now I do it on rare cases where I'm very uncertain or many discs are diseased, to try to limit my surgery. And so the article was on that little part of the patients. Mostly I don't. This case, no. He had clear degeneration of 2 segments, physical findings telling me that both were painful on examination, and that was enough for me. One of the evaluations that I do is to take pre-operative flexion extensions pictures, as I do again 1 year down the line, to see if the prostheses are mobile as expected, and today they are almost always, compared to the old times. But as you can see, as most of us, we can go quite far in extension. If we would just look at that extension picture, I would say, ooh, it has to be in a hybrid. But when he goes the other way, it's the dynamic of it, and that's why it's worthwhile stretching these muscles. If you look at this case that I operated 4-5, postoperatively there is almost no lordosis in the healthy disc 5-S1, but there is lordosis in 4-5 where it normally isn't a lot. And that is because the disc is so easily mobile and the muscles are still stiff, so they will shift him over in the most easily movable segment. Maybe this would alter with the viscoelastic prosthesis, but this is a sign for me that that patient has some more stretching to do to make the curve more physiological, mean regaining lordosis L5S1 and reducing it in 4-5. If you look at this case, the spine is, in my mind, pretty normal in sagittal balance in the pre-op case. Two very low discs, but as soon as I put two discs in and increase and restore their height, the muscles are too short, and the curve is changed by that. And that's the bottom line of our message. A lot of this is dynamic and dynamics that has appeared through the years where the patient has been in pain. And we have to respect that, and if we really do that, we can avoid our adjacent segment problem, that is facet joint arthritis at the index level. This is a case where a newly operated patient with an almost flat back, non-physiological curve, but that is not a problem. I know for sure that that patient, when I see 3 months down the line, has re-established a normal lordosis. Coming from that way to regain lordosis is never a problem. The problem is if they shift over to too much lordosis directly after surgery. This is a rare case, as we were speaking of it, with two segments that was not suitable for artificial disc replacement, but one was, and I really wanted to try to maintain mobility in some segment. I've done a lot of 3-segment artificial disc replacements and even 1 or 2 more than that. Today, most of the time, if it's a 3-segment patient or more than 2, I would make an ALIF in the bottom one, because the risk of tilting of the implants that I've also seen above when they start to get many. Maybe that's a shortcoming of today's the processes that I use, but I have adapted to that, and I cannot see the bad thing if you have 3 deteriorated segments that needs to be treated. If you have mobility in 2 of them, I think that is to be sufficient. Then we have the demands on our producers. They have to produce low enough implants so we don't have to stuff the segment, because that will only shift it into unphysiological segmental lordosis, putting the load on the facets. Now it's much better than it used to be because the implant manufacturers realized this. Also, the center of mobility, we have discussed upwards and downwards, but it has to be posterior of the midline. Otherwise, we also move the forces and the weight to the facets. And in my mind, the implant producers should make it easy for us, as was remarked about the viscoelastic, easy for us to see that we put the prosthesis in the functional midline of mobility, so that we don't give the probability of a unilateral facet joint arthritis because we put it the wrong way. So that is about what I was wanting to tell you. Thank you.
Thank you, Dr. Berg. Any question for Dr. Berg?
So how you assess facet joint arthropathy? I mean, we know that Fermin is for the disc degenerative changes, but most of the classification I've seen is like 0, where there is 2 to 4 millimeter joint space, and then stage 1 to 3. But I haven't seen anybody telling us when to do or up to what stage we can do a lumbar disc replacement. And secondly, is there any role for CT scan? Do you do it to assess or to confirm the arthropathy, or just relying on the MRI scan?
That's a very relevant question. In most cases, when the facet joints are healthy, I go just with MRI scanning. If I see a clear joint line and everything, I don't worry. If I'm in doubt, I would complete it with CT scanning because that's more exact for the bony part, but not for the articulate. I use the Fujimura, what's his name, the classification for the facet joints together with my radiologist. And the problem is that very, very rarely I do facet joint blocks, because if they are damaged, they are damaged. And if they're just compressed, since the disc is so low, they would probably having a good time when the height is restored. So it's more or less if patients comes back 3-4 years later and I start to question, have this patient develop facet joint pain, then I use the blocks. Was that an answer on your question?
Yeah, but what stage? I mean, if you're seeing what stage is that? I do a fusion that because of these facet changes.
Yeah.
What stage of facet orthosis do this replacement?
It's, I'll say as a former speaker, it's a little gut feeling. I know that a French surgeon called, his name was Lemaire, he's deceased. He did started a series with more severe facet joint arthritis. I've been talking with my colleague, Dr. Lueck, about it. And to my hearing, he did total disc replacement in cases that were much more diseased facets than I would. I think in the bottom line, if the surgery unloads the facets, you probably get by with some early arthritic changes. And that's what my presentation actually was about, to decrease rather than increase facet joint load after surgery.
Thank you very much.